I have an 8.5-year-old girl whom I have been treating for ADHD. And seemed like things were going along pretty well. And then several months ago, it was about 9 months ago, she wound up getting hospitalized at a local, well, not a local, but at a psychiatric facility because she was hearing voices. And
oh, no.
Yeah, I remember you guys telling me back in the day that pre-pubertal children who hear voices are very, very rarely psychotic, and it's usually anxiety.
Yes.
So she came out on aripiprazole and fluoxetine, and has been on those since, and is of course gaining huge amounts of weight because that's what happens. And it's actually it was about 4 months ago that she was put on the aripiprazole. And so I saw her recently. She's been seeing psychiatry, and they're keeping her on the medicine, and they recently increased the dose to 20 milligrams a day from 10 milligrams a day because she's still hearing the voices. So when I ask her, what she tells me is that, first of all, she only hears them at night. And second, that it sounds like people yelling and screaming, and there's never any words. And I freely admit that I am cynical and jaded, because I feel like anytime any kid says anything like that, they get put on these atypical antipsychotics. And I just feel like sometimes that's not the right answer. So I'm suspicious. But I thought I would throw this out there and see whether you guys say, or maybe you should think of something else, because A, the medicine's not helping and we're just bumping up the dose, and B, I'm not sure we had the diagnosis right to begin with schizophrenia. And C, I don't know.
All right. Can I go first, Barbara? Because I might pop.
Absolutely.
Because I might pop.
This is so upsetting to hear. I can't even begin. You are completely 1,000% right, even though I know nothing about this youngster. This is totally not acceptable, not standard practice, or it shouldn't be standard practice, even if it's done commonly. It's just horrifying. You are right for every single reason you mentioned. It is not how people present as the psychotic illness, number one. It is not the age of onset for psychotic illness, number two. There are so many other things that this could be, number three. Number four, it's not working. That's not a dose that makes sense. Now, oh my gosh, everything is wrong with that story. So you are completely correct. It's been reformulated, and she is learning to continue to say that she's hearing voices because it is getting people to respond to her distress. The key here is, what is it that's making her distressed, and or at night in particular, which is always a worrisome question with youngsters, right? But I don't understand what anybody could be talking to her about at her mental health visits that would allow them to say she's actually psychotic. That makes no sense to me. You are completely correct. And the worrisome part is, not only are they doing it, but I worry too that this family now maybe believes this about their youngster. So getting her off the medicine is going to be more challenging. And now
I think actually it might actually not be more challenging. Mom is not satisfied. She's scheduled, without my knowledge, I mean, they're on Medicaid, so care is challenging, but she's already scheduled an appointment that she's going to pay out of pocket for with an autism specialist. And I should say also that that the mom doesn't speak English. She's Spanish speaking. And so she has scheduled an appointment with this developmental pediatrician who has a private practice specializing in autism. I mean, this child's clearly not autistic, but she's searching for answers because she's not satisfied with the answers that she's getting. And I don't blame her. I'm not either.
Why
but
isn't
I
it
would
just
welcome some
anxiety?
advice on what to do next.
Why isn't it just anxiety?
Yeah, good question.
That is like common in the age group, simple to treat with English.
Yes.
Okay. I mean, mom would need to be involved in care. That's a little harder. And what's extra upsetting is that there is good literature that tells us that Medicaid patients and people of color, children of color, are at much greater risk for getting put on antipsychotic meds and left on them in exactly this kind of scenario.
Yeah.
She needs some parent management training to sort of change the way in which this youngster asks for help and people respond to her. She probably needs some cognitive behavioral stuff, a little bit of a behavior plan to reward her approximation of desired behaviors, and she needs a good SSRI that's well titrated to target what's actually probably wrong with her.
Okay.
I also worry about these kinds of kids, whether something ongoing is sustaining the worry, especially when I hear about a little girl being extra anxious at nighttime.
Right.
Well, let's be just a little more explicit here, and that is that sexual things happen at night. Shall we be explicit?
Yeah, no, yeah.
Right.
I wasn't trying not to be. I thought everybody knew. I wasn't, I just assumed that everybody knew.
Let's just make sure that everybody knows. And actually, I had a kid who started wetting the bed and being afraid at night. And it turned out to be her grandfather coming in and molesting her. So, so I know whereof you speak, and I just want to be clear that would be some of the line of questioning. Emily, do you want to comment at all about different cultural groups and how their symptoms of anxiety present? Would you like to say something?
I want to be really careful about being reductionistic, but I think there are some families where things are expressed more in a somatic way than in a psychological way. I don't know why this child chose this particular way to express her distress, but it kind of doesn't matter because at this point it has been so powerfully reinforced that it's where we are. So I don't know that that's so much the issue as the fact that she got hospitalized. And I don't know, I'm curious to know whether that was a scary thing for her, a relief for her, or how she kind of handled that. And then what was it like when she was there? Did the voices go away and whatnot? I think that's helpful to know about because often we see they come in, and if it were truly a psychotic symptom, it would not just vanish, right? And the other thing that's really important is that psychotic symptoms don't exist one at a time. And so you would expect to see some other evidence of a psychotic illness, some sort of disorganization or other odd behaviors or things like that, which we often don't see when somebody has said an anxious child is psychotic. But hallucinations are unfortunately sort of mistaken for being diagnostic of a psychotic illness when they're far from it.
A couple questions. Did somebody ask the obvious question about? She says what she hears are people yelling at each other. What was the?
Are people actually yelling in her house at night?
Are they really yelling? Maybe
the neighbors are yelling.
I don't know.
Yeah, that's a good. I mean, I didn't specifically ask that. I did specifically ask if there are any words that she can understand, and she said no. It's just like yelling noise.
Yeah. So I wonder about in her house and who's yelling in the house, and there may be I mean, a very clear message about who's yelling. Also, just to, not that it's primary at all, but you start out by saying she was followed for ADHD. Is she also on a stimulant?
Yes, she is.
And yeah, so sometimes, stimulants can make the anxiety worse. And so we're not wanting to put her on medicines that are making things worse. So,
and it's
Yeah.
possible actually that the initial diagnosis may even be wrong. So in other words, the most commonly mistaken diagnosis for ADHD is anxiety, meaning anxiety is the problem, not ADHD.
Right,
Anxiety
right.
Are you confident that you got the ADHD part correct?
I'd have to go back through her charts and remind myself that far back. Let me see here. How long ago was
Yeah,
that?
well, but actually, Bob, one of the things you're saying is really valuable. And I mean, lots of things you're saying are valuable, but one of the things that happens when you follow a kid over a long period of time, or you inherit one with a diagnosis, and that would be good for anybody else who might listen to this conversation, is that sometimes we get lulled into thinking we know the whole story, but in fact, we may have gotten it wrong from the very beginning, and just sort of, and because they seem to be getting better, that somehow we've got the diagnosis right. So it's always important to go back and look at the original diagnosis as well.
Yeah,
Well,
and
yeah,
I completely agree. And that's one of the things I always try to ask myself when things aren't going the right way, which is, did I screw up at the beginning and need to circle back and re-examine? So that ADHD diagnosis I made almost 3 years ago, so she would have been 5.
Little kid.
Yeah, and I'm looking back through some of these notes of my notes, and the initial visit where I said what Mom described was she's nervous and can't concentrate, and that she was frustrated at school. And then I look back through the psychiatry notes, and the first 9 months that he was seeing her, the diagnosis was ADHD and anxiety. And then in March, all of a sudden his note says she's having commanding auditory hallucinations. And that's when he started the Abilify. So that was 3 months ago.
Yeah.
But when I ask her about these voices, she says they've never talked to her. They've never told her to do anything. They only happen at night, and it just sounds like yelling.
Mm-hmm. Yeah. Well, at night, the stimulant's less likely to be a factor, but she may well have both ADHD and anxiety, although that symptom, the initial symptom about worries, isn't something I typically hear about an ADHD kid in kindergarten. The problem is they don't worry enough. So that and the stimulant certainly magnifies worries. You focus more on your worries. So
Sure.
So that would be I've been thinking about we're wondering about the value of the medications, and certainly the atypical is the one we're worried most about. But if you certainly want to get teacher ratings and see about stopping the ADHD medicine, see the teacher ratings, and then as you start to, if you decide to taper off, which I hope you do, the atypicals, you could also have that objective data to follow.
Yeah,
I think
and that sounds good, and that's kind of what I was thinking, but I didn't want to do it until I talked to somebody who sees having hallucinations and who have these kind of issues regularly, before I just said, you know what, I think I should go against what the pediatric psychiatrist is saying and we should stop all the medicine. But I think maybe what we need to do is stop her medicines and regroup, and I need to take some more history in terms of what all's going on around her and see if we come to the same answer or potentially a different one.
Yeah. me say that from my point of view as developmental behavioral pediatrician, the context in which I see actual psychotic symptoms the most in young children are kids on stimulants, and the psychotic symptoms go away when you stop this.
Right. Yeah.
So not to say that psychotic symptoms, but I think that that all makes me concerned about both the stimulant and the atypical.
I would say that I feel pretty darn confident that she is not psychotic. So although she may or may not need the stimulant, I don't think this is a stimulant side effect problem. I just want to be really clear about that. And
yeah, I don't think so either.
Yeah, and so I think that as a child psychiatrist who has seen many youngsters, I've never seen an 8-year-old with true psychosis unless they were toxic, they had ingested something and they were delirious.
Yeah.
So I think it would be extremely unusual for this child to be psychotic. And actually what you're describing of her description is not a psychotic description anyway. And so I think this is really just awful. And I think, you know, one thing to think about too would be to take a history with mom with a translator about the psychosocial context. And there are also some tools that might be worth using in terms of look like a scared her and asking her some of those more targeted questions, even maybe some PTSD kinds of things, that she may be getting scared at night. And maybe ask parent mom too about like parental stress burden. There's some tools for that. Barbara, I don't know if any of those are in Chattis or
everything you said so far is in Chattis.
Yeah. So
Okay.
I don't know if you use Chattis or not, but I think those would be things that the value of doing some standardized instruments right now or semi-structured kind of survey things like that would be because you're going to be disagreeing with the prescribing psychiatrist, it would be in your interest to have some documentation. And then you can also use those instruments to track change.
Yeah.
Direction, you can just sort of document what's getting better and what's not. I'd also be curious, I know it's the end of the school year, but whether she has any of these kinds of concerns at school or whether there's anything upsetting her at school.
Right.
And so talking with the teachers would probably be worthwhile as well.
Okay. All right. I appreciate your input very much. I've got to run, but I really thank you for the time.
Absolutely. Fingers crossed.
Thanks
Wait,
so much.
I gotta say that watch out for what's happening in a sleep disturbance because a reason for hearing scary noises at night is to get in bed with your parents. And so you got to know how they're handling this as a sleep disturbance also.
Well, and one other piece of first aid, in addition to all the things that Emily said and try to sort it out and have her manage these things, one piece of first aid, I think, would be to have mom read a story to her at night and stay in the room till she falls asleep. Just whatever it is, be able to have that as a safe time to engage and because the two things, one is maybe something's happening and the other is that anxious kids are more likely to be anxious when it gets to be dark and even they may be used to sleeping together, whatever, but I would presume I'd prescribe mom to read a book and stay in the room until she falls asleep for a week or so. Okay?
All right. Thanks very much, everybody. Appreciate it.
The interesting things about this case is that once the ball has started rolling in a very serious direction and you've got a hospitalization and you've got specialists who are saying that's what's going on, it becomes increasingly difficult for the primary care provider to turn things around. So, or saying, wait a minute, this doesn't smell right. I don't think that this is really what's going on. And getting some advice about it because that's a problem. The other thing that I think is particularly interesting about this is how much of a language barrier is there? So because somebody got the history from the parent who speaks Spanish, and I don't know how well.
No, we don't even know that anybody got a history from the parent, actually.
That's true. Maybe
we don't.
got a history from the kid. That's right.
Right.
But somehow ended up in the hospital, you would think that there would have had to be a well-translated communication with the mother. Possible there wasn't.
No.
Yeah. Yeah, you've seen that.
Yeah, too many times.
Yeah, that was.
Yes, I did have a question, and to stay on the ADHD, I've been managing a 13-year-old ADHD, more the inattentive, not hyperactive type. Came to me, I kind of was the PCP had referred to me just for a second look on meds, had some pretty significant weight loss on Vyvanse. So I took him off it and then tried all the non-stimulant medications, and gave them adequate time, maxed them out on doses, really did not have any benefit, was really struggling in school. Teachers noticed, really the inattentive, but his weight went up, obviously. So I see him back a couple weeks before finals, and I had put him back on the Vyvanse. He wasn't on a high dose. I think he was on 40. So I said, I'm going to put you on 20 because that medication obviously works a little bit faster. We were up against a time frame, didn't want to see him finish out the end of the year on a negative note. So I put him back on some Vyvanse, did okay. 20 wasn't cutting it. 30 was kind of a sweet spot for him. But again, struggled with the weight loss here, and we don't have a whole lot of room to move, in the lower classification of BMI, like 10th percentile or around there. So, what is your suggestions or when a stimulant medication works very well and the benefits, they do really well in school, and medication holidays obviously have their time and their place, but when I'm talking more about a 13-year-old whose executive functioning at this age is extremely important, we think more continual use rather than medication holidays. So I'm really I'd like to learn more about that, what your take on using appetite stimulants, on a cycling basis when we are using a stimulant medication. Just wondering some thoughts on there.
So can I start on this one?
Yep.
So first of all, Vyvanse is my least favorite stimulant. But one of the things to keep in mind is that it lasts a lot longer than other stimulants, and that it may last the entire time this child would have a chance to eat.
Right.
And sometimes complicated by parents not letting the kid come out of their bedroom when they finally are hungry. And so I don't use appetite stimulants very often. I think I've done it twice in 30 years.
Okay.
But let me just say that I think that you need to change this kid's medication regimen so there's more room to eat. And that's really the most important thing to do. And that may mean taking it later in the morning. It may mean giving a shorter medicine, especially during the summer if medicine's still needed, so that he can eat lunch, he can eat dinner, and he can eat something before he goes to bed. And by the way, puberty's on your side. It's very difficult to suppress appetite completely during puberty.
Yes, yeah, and that was again a back thought in my mind too. So, and I should have prefaced also, had tried Adderall in the past, did not do well with it, GI upset, and definitely some mood disturbance also. So, and he's been on Vyvanse for let me see here, at least the last 2 years, and has done, grades have been this is been reported, that he's done the best on this. Teachers notice he does well. Again, it's just that appetite is just really an issue here. And I like, the methylphenidate class too. That's actually my first go-to. I don't use Vyvanse straight out of the gate. But I was just kind of wondering, what, if there was any, and I haven't found too much good research. It's kind of well, you could try it and see if it works, on what the benefits are of using, an appetite stimulant in cases like this.
Yeah. Well, so again, you've heard my vote, and that is change the other medicines and optimize them first.
Yeah.
Okay.
But sclerotectin does psychopharmacological effects of other kinds. And so it's really something I would say overall to avoid. And even in kids who have, I had a kid who had had like Crohn's disease and ADHD, where he wasn't feeling good in other ways, and the ziproheptadine made a big difference for him. But really, that's never my go-to. Right?
Okay.
Yeah, well, I agree with that. Yeah, I guess, I don't know if school's out to try to switch him to Vocalin or something like that would be for the same reasons. But also, I think first, just in general, the people, sometimes doctors stop using stimulants and parents get upset because it suppresses their appetite. I feel that if it doesn't suppress their appetite, they're probably not getting the stimulant effect. I see it as an expected thing, but then of course you're going to be watching the BMI, and you're saying that there's some sloping there, so my first go is something I call it the fourth meal, and I like prescribe it, and I say, it's a half hour before you go to sleep, and you have to formalize this. Don't wait for the kid to say they're hungry, because they're most impulsive and they forget about being hungry at that time.
Right.
As Barbara can wake up later, but sometimes they don't. But so I try to get them to, everybody's going to sit down. It's going to be like a bedtime snack for some people, but it's going to be also his mealtime supper microwaved over. And so that's my first, and I usually say that at the very beginning. And then I agree with Barbara, if the stimulus is still acting at that time, then you're going uphill. And the other is breakfast. They have a good breakfast. And, if they miss lunch, and I tell people that you can expect them that they might miss lunch. And then I say, sometimes I say, that it can get controversial, that it was interesting to me that during Ramadan, where the Muslims are not eating lunch at all, anything during the day, they gain more weight during that month than any other time. They take in more calories. It just, at the end of the day, they overdo it, actually. But so that lunch is a little bit on the optional side when you look at that model. So the parent's reaction to appetite suppression, I try to sort of give them some expectations that's going to happen. And then the weight, and then my second thing is if they're doing the fourth meal, and and they're not getting other side effects from the stimulant. It's really helping them. You've got the right dose. I think you said, this is a sweet spot. But I will give them Pediasure milkshake at the end of the day. My next
or for breakfast.
Or for breakfast, yeah.
Yep.
So those are the things I'm doing. I'm not throwing ziproheptadine in.
Yeah.
Okay.
And the parent is very, very hyper aware too, like of the appetite and things also. She really is on top of him and is eating and encouraging also. So that's very helpful too. The mom's very in tune to it. So that's
I would offer some similar and maybe a slightly different approach. I do not use ziproheptadine ever. I also do not use Vyvanse. The reason I don't use Vyvanse, there are a couple of them. One is that it's brand only, and so it's very expensive. And I just have a philosophical objection to that. Number two, it is so long acting that probably 90% of kids get into trouble with sleep as a result of it. And I think that's a problem. And then appetite, as you're describing, is also really common because it does last so long. The other thing I don't care for is somebody who really needs a lot of stimulant typically has a lot of trouble in the mornings, just sort of getting ready, getting going. They miss the bus, whatever, because they're disorganized. So the thing about the way Vyvanse was marketed is the low abuse potential, right? Because you can't snort it, because it needs to have the molecule needs to be cleaved in your GI tract to make the active drug, right? That's the thing about Vyvanse. the problem with that is that all regular stimulants, the way stimulants work is that we have a gut receptor for stimulants that picks up a regular stimulant in our stomach, and it takes about 30 to 45 minutes to get into our bloodstream. That's why we say a regular stimulant takes about 30 to 45 minutes for onset of action, right? Because there's no first pass to the liver, whatever, it's immediately active. The problem with Vyvanse is that it takes 30 to 45 minutes for the molecule to be cleaved into the active form. Then an additional 30 to 45 minutes to get picked up by your gut tract. Talking an hour and a half. And a lot of times families can't manage that, so the kid ends up on an additional regular dose first thing in the morning. So now you have a kiddo on a really long-acting stimulant, but it's not working quickly enough, so they get a regular dose, and then it's interfering with their sleep and or their appetite. Then we're giving them a medicine for the side effects that we've caused. So I just don't use it for those reasons. Another strategy, though, if you really work through every other drug, and this really does seem to help him, because you have that hour and a half, he needs to eat like a Denny's all-you-can-eat buffet breakfast to get as many calories into him before that hour and a half mark where the medicine's going to start to kick in and cut his appetite. So that would be the only other strategy that I would offer, that the minute he wakes up, he needs to be chowing down to get maybe 1,000 calories in him.
Yeah.
Okay. Yep.
So I have a question for Emily, and then another comment about big breakfast. I'll make my big breakfast comment first, and that is one of the problems with teenagers, as you know, they're not biologically ready to go to school at the time the school starts them, which is typically earlier even than, he's probably in high school, or junior high, too early for their sleep cycle. So they're not hungry. They're like nauseated when they get out of bed, and they're in a rush. So that's where a milkshake or Pediasure is very valuable, because you can drink it as you run out the door. So they may not have time for Denny's, but they've got time to take a big drink. And using making a homemade milkshake and adding corn oil and egg beaters, which is, pasteurized eggs, you can actually get a very high calorie drink into 8 ounces that they can swallow on the way out the door. So that was my other comment about trying to get kids to take enough calories, because the morning is a problem for many teenagers. Then I have a question for Emily, and that is, I was having some experience with, as I said, I don't use Vyvanse either, but I inherited some kids who were on Vyvanse, and found in some cases, after they'd been on it successfully for 3 months or so, they began getting very aggressive and violent. And I wonder whether you've seen any reports about that, because I only have my anecdotal evidence. I try not to be anecdotal, but it was enough to make me make sure they got off of it. But I wonder whether you heard of that in others. I guess you're not using it yourself, but have you heard of it?
I was going to ask the same question for Anna.
I have not heard of that, but I think they make kids irritable. And so if there's any propensity to an affective syndrome, I'd worry about that being what's going on. But no, I haven't seen anything about Vyvanse making people aggressive.
Okay. Barbara and I both felt irritable, is what I would say, toward the end of the day, more than the other stimulants. You switch them to Adderall, and it didn't happen. Right. So it may be that it was the accumulation of not sleeping and not eating or something.
Right.
I really think that's possible, that we were seeing. But
absolutely.
Those are anecdotes.
Natalie, do any of those points we've just made apply here, or to any other patients you have?
Yeah, and a lot of those dietary ones too. I'm a huge proponent of a milkshake or Pediasure, any one of those. That's my go-to first. As far as dietary, getting in extra calories, extra fat, extra protein, that kind of stuff. So that's something I do use in my teaching. I will certainly revisit, changing up the stimulant medication. And I think I was probably pigeonholed. You know, this patient was newer to me. It was reported, you know, that this medication had worked the best for him. So my thinking was I was kind of staying in the box, not looking outside. And I was like, all right, so how can I help with the side effects, you know, rather than, hey, let's see if there's another medication that we could actually decrease the side effects. So, and that's why we have conversations about it, you know, just for like, you know, a second opinion. So, and again, you know, there is some reading out there on using that, but again, I hate trying to curb and use a medication for a side effect, you know, especially when there are other options out there. So, you know, I appreciate the discussion. It's certainly going to help me, you know, as I treat this patient moving forward.
Natalie, one other question. You said that the child was at the 10th percentile for weight. How about
maybe
for height?
13th? This last time was about 13th. Height, let me look.
But I'll tell you why I'm asking. Because sometimes so we're focused on height, but when you have a kid who requires a lot of stimulant and is also short as well as low weight.
I do see a lot of that. Yep. I often see more low stature. About 40th percentile. 40th for the height.
Okay, for height, then that's not it. Because sometimes you want to be thinking about fetal alcohol syndrome for kids like that.
If they're small.
If they require a lot of stimulant and shorter and also, but not.
And he really hasn't required high doses of stimulants. Again, he's more the inattentive, you know, they tend to require less. Again, I think it was just me staying inside the box and not saying, hey, let's change, you know, let's try a different stimulant. And that's the beauty in stimulants, is that there are a lot of options, you know, and they tend to work faster than a lot of other psych meds too. So, you know, I kind of reassure parents, hey, it may take us a couple times, but good news is we don't have to wait 4 to 6 weeks with starting each of them. So, you know, that's helpful in that aspect.
Yeah, well, you got another opportunity. It's called summertime. You can.
Yes, exactly. Yes, I do appreciate that over the summer in some of my patients too, because it's helpful. However, the inattentive ones, I tend to struggle like with them a little bit because there's not a huge, we're not able to measure it as much as we are the hyperactivity, you know, in some of those patients. So I kind of rely on the parents, you know, to help me with that, because there's just not as much schoolwork unless they're getting tutoring or things like that over the summertime, but there's not as just much a measurable benefit, you know, if we're looking at more the inattentive type.
Yeah, but at least short action.
Just my big exception that is kids who are driving cars.
Yeah.
The data on kids with ADHD, that if they're driving without their medication, they're driving about the same as somebody who's intoxicated with alcohol in terms of their ability to tend to the task. And so it's one of the reasons that ADHD can kill you is if you are driving a car.
Yes.
This is only 13. It's generalizing to the conversation about take them off during the summer if you can, but depends on what activities they're doing, whether that's safe or not.
I tend to also use short acting for their tutoring sessions.
Yeah, me too. Yeah.
Yep. Yes. Right. Just using right. Absolutely. Yeah. I often do that. So sometimes in the summer, if I need to, with in my less than 16-year-olds, not my 16-year-old new drivers. No, that's a daily medication, daily regimen.
Okay. Got any other things that you'd like to bring up?
No, I think that was the one question, and then I liked the discussion about the other patient before. So that was all I had for this week.
Yeah. Emily, do you see very many kids with fetal alcohol syndrome? Because, you know, this idea that the dose of stimulants that finally works, which it does, seems to be much higher in kids with that.
I don't, I mean, we see kids like that on the inpatient unit, which is where I work. From an outpatient standpoint, they're mostly cared for, you know, over at the Kennedy and the fetal alcohol program. I don't
Yes.
really know if they have a different protocol. I've not seen that to be true. Most of the kids that have some sort of, if you will, brain damage or suboptimal protoplasm like that, like ASD kids as well, just don't tolerate stimulants in general. And again,
Yes.
I'm seeing kids that have straightforward ADHD. I'm seeing the kids that are more complex typically, or comorbid, or things aren't working. That's why they end up in child psychiatry, or certainly on the inpatient child psychiatry unit. But I have not seen that to be the case, no.
Yeah, it's interesting. That may be a difference between child psychiatrists and developmental behavioral pediatricians. Is I see lots of kids with fetal alcohol syndrome.
Yeah, they go to the fetal alcohol. I mean, part of it is where I am. We have a fetal alcohol center.
Yes.
So they go there, which is developmental pediatrics, and child psychiatry. But I just don't see them because I happen to work at a place that funnels them someplace.
Yeah. Yeah, exactly.
Yeah, so that may be anecdotal what I said, but that was in my observation that they tolerate them fine, but they just need larger doses, and,
Right.
and it really makes a huge difference if you
Got to be brave.
are able to do it.
Yeah, Natalie, maybe you have a comment about that in your own practice.
I really don't see a lot. Even when I was working in specialty child psychiatry, I saw a lot of reactive attachment kids, lots, and they often would come to me after having a diagnosis of ADHD from their primary doctor, and maxed out on stimulants, and were just at a brick wall, and that's when I would get them. But I really don't have a good experience with any kind of fetal alcohol, or some NAS kids occasionally, but not a high lot of our population.
Right.
All right.
Okay, well, thank you very much. Tell your colleagues to join us in the future. Thank you.
Yes, thank you.
All right, bye-bye.
Take